It's really my pleasure and privilege to be here, and I would just like to add one addition to the thanks. Gretchen graciously did not thank herself, but I think she deserves all of our thanks, so thank you, Gretchen. So when I first meet with someone or a family where the diagnosis of Loeys-Dietz syndrome is first being made, I tell them that if you go to the internet and you start reading about Loeys-Dietz syndrome, that you're going to find some scary information. What I tell them in the same breath is that much of that information derives from our really early experience. The people that made themselves known to us first were often the most severely affected people. And also that early experience reflected what happened before we knew this was a different condition, before there were treatments that were geared specifically for this condition, before the use of medications that might be particularly powerful to alter the course of this condition. So the message that I want to get across to them and to you is that I know deep in my heart that things are much better even now, just 7 years later, than they were at that early stage, and that they're going to be even better very soon. And I want to share with you some of the information that provides to me that optimism. So as Bart mentioned, there's an intimate relationship between many different conditions. And in order to fully appreciate where we're going with Loeys-Dietz syndrome, what's guided our thinking about Loeys-Dietz syndrome, I think it's important to consider where we are now with Marfan syndrome. This is a condition, again, that's very similar. This is a condition that has taught us many lessons. It's something that we've been able to study for 30 years as opposed to 7 years. So I'm going to begin, but only briefly, to tell you about the foundation that we learned by studying Marfan syndrome, and then bring you into our current understanding of Loeys-Dietz syndrome. So Bart nicely described the physical features of Marfan syndrome, including the eye lens dislocation, the overgrowth of the long bones, most importantly, the progressive dilatation of the aortic root, and mentioned that we learned back in 1991 that Marfan syndrome was caused by a deficiency of a protein called fibrillin-1. So what did we know about fibrillin-1? Well, we knew that molecules of fibrillin-1 bind together to form complex structures that we call microfibrils, and that we also knew that these microfibrils, shown by these little black dots, cluster around a forming elastic fiber as we're growing in the uterus when we're embryos. So this really led us to the firm belief that these microfibrils need to make a lattice upon which an elastic fiber is built during embryonic growth. And if you think about it, this really boded poorly for the development of treatments. It suggested that children with Marfan syndrome are born with inadequate elastic fibers in their tissues, that the tissues are simply weak, and that there's nothing that you could do to improve the quality of those tissues after birth. The game was over after birth. So as in most advances that I've made during my career, insight came from a clinical interaction. I was in a patient room looking at a child with fingers just like these very long fingers, and a father challenged me. He said, you know, this just doesn't make sense. Why would weakness of the tissues cause the bones to get long? For that matter, why would weakness of the tissues cause the facial features that we see in Marfan syndrome? That doesn't make sense. It doesn't add up. Why would weakness of the tissues cause the low muscle mass and low fat stores? And it really challenged us to think differently, to get out of our little box of thinking, and to try to understand what else this fibrillin protein might be doing. Now, Bart already took you through this slide. What we learned is that these microfibrils that are composed of fibrillin-1 serve a second important function, not just a structural protein, but rather they bind this growth factor in the body called TGF-beta. TGF-beta, you can think of it as a molecule that tells cells how to behave. It tells the cells when to divide, where to migrate to, what proteins to make, and when to die. And we learned in Marfan syndrome that if you have inadequate microfibrils and TGF-beta gets released, the body then activates this growth factor that then goes through the cascade that Bart mentioned, prominently including activation of a molecule called SMAD2 or SMAD3. It's activated with this little addition, which is a phosphate group, and that this leads to many of the consequences of Marfan syndrome, because in Marfan mice that are still lacking fibrillin 1 and still would have weak tissues if that were the whole story, you could prevent all of these simply by blocking TGF-beta. So that told us TGF-beta is important. It's not just a bystander, it's really doing something bad. So at that time we asked, well, what can we do to help people? And we challenged ourselves with the question, is there a drug, and even better, an FDA-approved drug, that might mimic some of this protection that we see when we block TGF-beta? And our attention turned to the drug losartan, a very common, very safe blood pressure medication, because it was known that it not only lowered blood pressure, but also had the ability to block TGF-beta. So that sounded like a magic bullet, doing two good things. So losartan works by blocking a pathway by which a molecule called angiotensin II regulates our blood pressure. And this angiotensin II molecule can activate both a type 1 receptor or a type 2 receptor. Activation of the type 1 receptor is known to activate TGF-beta, the culprit. And activation of the type 2 receptor actually blocks production of TGF-beta and activation of TGF-beta. So we didn't want to completely block the production of angiotensin II. We wanted to simply block this side of the pathway because we reasoned that this side might be doing some good. So we did what we call a blinded study in our mice. We took large numbers of Marfan mice. Half of them got losartan, half of them didn't, and we asked, did it make a difference? But the person interpreting the data had no clue which mouse was receiving which drug. We didn't want them to be biased in their interpretation. And what we found is that if a Marfan mouse received a placebo, basically no drug, their aortas grew really fast. If we just gave them a blood pressure lowering medication, a beta blocker called propranolol that does not address TGF-beta, it reduced aortic growth to an extent. But if mice received this losartan medication that both lowers blood pressure and blocks TGF-beta, their aortas grew just like what we call a wild-type mouse. A wild-type mouse means a normal mouse, a mouse that doesn't have Marfan syndrome. And that we also saw that this protection associated with decreased activation of our TGF-beta marker, this pSMAD2 molecule. So this really looked good. Now, remarkably, this blood pressure medication also addressed features outside of the cardiovascular system. It caused the mice to avoid the emphysema or widening of air spaces that we can see in Marfan syndrome. It caused the skeletal muscle in these mice to become bigger and stronger. So it really was not the blood pressure effect that was important, it was its ability to block TGF-beta throughout the body. So, there is now a large clinical trial of losartan in Marfan syndrome that's going on, but pending those definitive results, we felt compelled to treat a subset of children that had the most severe form of Marfan syndrome. These children show unrelenting growth of their aorta despite maximal treatment with other drugs, reaching surgical endpoints in very early childhood. So then we identified these very severe children and gave them losartan, and found that after receiving losartan, their aortas simply stopped growing. It just plateaued. And that has been sustained, for example, in this child for now 8 years. No further growth of their aneurysm. We're learning that there may ultimately be better drugs and better doses than losartan. In this very severe young lady with Marfan syndrome, we found that losartan slowed things down for a little while, but ultimately the aorta started growing again. When we switched her to a family member of losartan called irbesartan at a very high dose, we were again able to achieve this plateau in aortic growth. So we're not going to sit back and assume that this is all going to be perfect and that we know all the answers. We're trying to identify whether other medications that address other activities or other molecules might be even better. I've told you all about this TGF-beta pathway and all these SMAD proteins. That's called the canonical TGF-beta signaling pathway. But the TGF-beta receptor can do other things. It can also activate pathways that are called the non-canonical TGF-beta pathways, prominently including a molecule called ERK. So I know that there's a lot of science that I'm talking about here. The message so far is TGF-beta is bad. What about ERK? Is that bad too? So we went back to our Marfan mice and we looked at the level of activation of ERK, and we saw in the Marfan mice it was extremely active compared to mice that didn't have Marfan syndrome. We learned that this ERK activation that we saw in our Marfan mice was completely eliminated by blocking TGF-beta with what we call a neutralizing antibody. We found that our wonderful drug losartan that was so protective also blocked ERK activation. And now we've gone on to test a different drug, a drug that's called RDEA-119 that specifically blocks ERK. And we found that in mice that were untreated, there was rapid aortic growth, but if you blocked ERK, the aorta actually got smaller over time. So that was really an amazing result. We're working now with drug companies to explore medications such as RDEA-119 for the use of, to treat people with connective tissue disorders. Right now, this is an experimental drug, so there's still a long process that we'd have to go through to be able to deliver it. But the bottom line is that there's other things coming along. We can expect more and perhaps better drugs in the future. Now, I want to stress that we have to be equally invested in finding things that work as well as things that don't work. There's a class of blood pressure medications called calcium channel blockers that are very commonly used. They're considered to be very safe. Currently, they're the second-line drug that would be used in someone with Marfan syndrome that can't tolerate beta blockers. But no one had ever proven that they do anything good, and nobody had ever proven that they don't do something bad. So we decided, let's use our mouse models and look at calcium channel blockers. So what we found is that this is the heart and the ascending aorta, transverse aorta, and descending aorta of a normal or wild-type mouse. Here's our Marfan mouse model, and it's got a flare of the aorta right at the base. If we give a normal mouse, a wild-type mouse, the calcium channel blocker amlodipine, you really don't see much going on. Perhaps the aorta looks a little generous, but in virtually every mouse with Marfan syndrome that we gave amlodipine, we saw the formation of these giant aortic aneurysms. In fact, their aortas tripled in size in 3 weeks once they were given this calcium channel blocker. When we look at the tissues, here we're looking at the aortic wall. In a Marfan mouse that received no medication, we see that the wall is slightly thickened. We see that the elastic fibers shown in black are a little bit irregular. But if you give a Marfan mouse the calcium channel blocker amlodipine, look what happens to the aortic wall. It's massively thickened. The elastic fibers are simply falling out or dropping away, and the aortic wall looks tremendously abnormal. If I show you this quantitatively, Marfan mice show more rapid growth of their aorta than a normal mouse. If you give a Marfan mouse a calcium channel blocker, it grows even faster. Further up the aorta, in what we call the ascending aorta, Marfan mice that receive no medication show a perfectly normal size of their ascending aorta, whereas if you give a Marfan mouse amlodipine, look what happens. The aorta is just growing like crazy. And this is not something that's innocent. These mice that were given amlodipine start to die from aortic tear within 5 weeks of starting the medication. So we now have learned that it's because calcium channel blockers increase the activation of SMADs and ERK compared to mice that don't receive calcium channel blockers. And we've also seen this identical effect with every calcium channel blocker we've tested. So we think it's a class effect. It's not just amlodipine that's a bad drug. We went on to show that it is indeed ERK activation that is important, because if you give mice both amlodipine plus our ERK blocking drug, you prevent this tremendous abnormal growth of the aorta, and you also prevent the death seen in the mice that were just given the calcium channel blocker. Now, we still have a lot to learn about people, but this is telling us that you can't assume that every blood pressure medication is good for you, that you have to be selective, that you have to ask the hard questions, that you have to ask for proof when someone says you should take this drug and not that drug. So Dr. Loeys nicely described the phenotype, the presentation or features of Loeys-Dietz syndrome. And I personally had the ability to either have direct contact with or to care for about 200 families from a distance. So I've been personally involved in the care of about 200 families. Dr. Loeys explained that we were able to show that this condition is caused by mutations in the genes that encode the receptor for TGF-beta. This was a great finding if you think about it, because we had already learned a lot about TGF-beta in Marfan syndrome. We already had ideas about how we might modulate TGF-beta. So it was really, I think, good that this new condition might tie into what we had already learned. And as was mentioned, in people with Loeys-Dietz syndrome, here we're looking at the aortic wall, we see a lot of excessive activation of our marker of TGF-beta activity, this phosphorylated SMAD2. So now we've gone on to make mice with Loeys-Dietz syndrome. This is a long process, but we actually introduced mutations in both the type 1 receptor gene and the type 2 receptor gene. And we saw that mice that have mutations that had been seen in people with Loeys-Dietz syndrome showed very rapid growth of their aorta compared to wild-type or normal mice. We saw that the aortic wall, once again, looked very abnormal, just like we saw in the Marfan mice. We saw that the Loeys-Dietz syndrome mice showed tortuosity of their blood vessels. Here we're looking at the coronary arteries, and you can see how windy they are compared to the mouse that doesn't have Loeys-Dietz syndrome. And we showed that our Loeys-Dietz syndrome mice, if left untreated, showed a death due to aortic tear compared to mice that didn't have Loeys-Dietz syndrome. We also found that these mice show the skeletal features of Loeys-Dietz syndrome, including curvature of the spine, including premature fusion of the skull bones, the term craniosynostosis that Dr. Loeys was talking about. So this now provides us the opportunity to start doing the same kind of experiments that we did with Marfan syndrome, to ask what makes a difference, what makes these mice better, what makes them worse. So the first thing we wanted to do was to show that this TGF-beta signaling pathway was clearly altered, and altered in the same direction, more activity as we had seen in Marfan syndrome. And we clearly see that in our Loeys-Dietz mouse that has a mutation in the type 2 receptor gene. There's much more activation of our TGF-beta marker than there is in a mouse without Loeys-Dietz syndrome. We now have gone on to do a trial of losartan in the Loeys-Dietz mice, and we did this in a blinded way, just like I described for the Marfan mice. Once again, if these mice were not treated, we found that they had very rapid growth of the aortic root. We found that their elastic fibers were breaking down very quickly, again shown up here. We found if you gave Loeys-Dietz syndrome mice losartan, their aortic growth was perfectly normal, just like a wild type or normal mouse without Loeys-Dietz syndrome. And we found that the architecture of the aortic wall, the integrity of the aortic wall, was also perfectly normal. So this is, again, one of those results that you pray for and that causes you to sort of drop out of your chair when you see them for the first time. This is not only a slight nudge in a good direction, this is achieving exactly what we would have prayed for, and that is a complete reversal of this tendency for abnormal blood vessel growth. And once again, this happened by blunting TGF-beta activity. Bart told you about the new gene, the TGF-beta 2 gene, that is also now associated with a Loeys-Dietz syndrome-like condition, and he showed you pictures that included facial features and this tortuosity of blood vessels and aortic root enlargement. He showed you that the aortic wall in these people looked just like classic Loeys-Dietz syndrome and just like Marfan syndrome. He showed you that they also have increased activity of TGF-beta in the aortic wall. We've now made mice with this condition. We want to be comprehensive. We want to learn as much as we can. And we found that mice with mutations in this TGF-beta 2 gene, not the receptor, but the molecule that binds to the receptor, they also have large aortas compared to normal mice. They also have high ERK activation and high SMAD activation, so high TGF-beta activity. If you breed them to the Marfan mice, so the mice have both a mutation in the TGF-beta 2 gene and the Marfan gene, those double mutant mice shown in orange are worse than either single mutant mice. This tells us we're in the same pathway. It's the same process where our thinking is right. We have to try to keep confirming that. And we also, again, see very, very high TGF-beta activity. So now I think the message that I want to get across is people with Loeys-Dietz syndrome are not alone. There are many conditions that relate to the same pathway that we call the TGF-beta vasculopathies. My bet is that advances made for any of these conditions are going to inform the treatment of other conditions within this group. We can build upon other people's observations just like they're building upon our observations to try to do better for treatment. I want to end by something that I think is really exciting to me. We're really trying to address every problem that someone with Marfan or Loeys-Dietz syndrome would face during their lives. And one such problem is that women with these conditions tolerate a pretty high risk of death due to aortic tear if they become pregnant. We know pregnancy is a risky time. Now, this risk has been attributed to the high hemodynamic stress of being pregnant and of delivering. But it seems notable that the vast majority of the tears of the aorta occur within the few weeks right after delivery. They don't occur during delivery or right before delivery, but instead after delivery. So that seemed odd. What also seemed odd is you couldn't prevent these tears from happening by doing a cesarean section, by preventing a woman from pushing during labor. So that also seemed odd. Is this hemodynamic stress hypothesis really true, or are we just being distracted by that hypothesis? So we asked a simple question. We asked what starts at the end of pregnancy is maintained after delivery and might synergize with some of these pathways that we're thinking about, might make them worse. And we came up with a pretty strong hypothesis that it's release of the hormone oxytocin. So when a woman is ready to deliver, their body releases a hormone called oxytocin that stimulates uterine contraction, and then oxytocin stays on after delivery because it's also needed to promote milk letdown if a woman is breastfeeding. We know that oxytocin is sustained after delivery. We know that the receptor for oxytocin is increased in the aorta in response to pregnancy. So this seemed like a perfect storm. More receptor, more oxytocin, something that's maintained after pregnancy. We got really excited when we learned how oxytocin stimulates the uterus or milk letdown. It does that by activating ERK, our old criminal culprit, bad guy. So we decided to do a very simple experiment to test whether oxytocin is at least part of the story. First, we went back to our Marfan mouse model, and we found that virtually 100% of pregnant mice that deliver and breastfeed die due to aortic rupture within the couple of weeks after delivery. So it gave us a great mouse model to test. And we asked, well, what would happen if we allowed these mice to become pregnant, allowed them to deliver, and then simply took the pups away and prevented them from breastfeeding? Might that alter the rate of death? And the answer was that if we allowed them to breastfeed, 96% died due to aortic dissection. If we took the pups away, 70% survived, no aortic dissection. So we increased the survival from pregnancy from 40% to 70% just by avoiding breastfeeding. We're now looking at when the aorta grows rapidly during pregnancy, and we learned that all of this growth is happening within the couple of weeks after delivery, and that if you just simply take the pups away, you can avoid this abnormal aortic growth. And then we did kind of a crazy experiment. We asked, well, let's really prove that oxytocin is bad. Let's give it to male mice and see what happens. So we gave male mice oxytocin. Their aortas grew really rapidly, and they started to die from aortic rupture. So it's really proved to us that this hormone, this natural hormone, is not a good thing for people with connective tissue disorders. We've now made a knockout mouse that doesn't have the oxytocin gene at all to see if it's protective in Marfan syndrome and Loeys-Dietz syndrome. But the great thing is that there's already an FDA-approved drug that blocks oxytocin called atosiban. And so it's already in clinical use to inhibit preterm labor. If we can prove all this, that would be a treatment to prevent aortic tear in women with Marfan syndrome and Loeys-Dietz syndrome who choose to get pregnant that could start tomorrow. It's already on the market, already safe. So I think it's pretty wild that 7 years ago we had this very pessimistic outlook, that you had weak tissues and there's nothing that you can do. We now have over 7 treatment strategies that are being tested in mice or have already proven to be protective in mice, and we've learned which drugs we should avoid. In the last 2 minutes, I'm going to tell you a little bit about allergic disease in Loeys-Dietz syndrome. We've heard that food allergy is very common. We heard that many of these children require EpiPens because they can have severe allergic reactions. We learned that these children also often describe eczema, seasonal allergies, and asthma. We also learned that there can be a very inflammatory state in the esophagus called eosinophilic esophagitis, where these red cells that we call eosinophils infiltrate into the esophagus. We also learned that there's increased prevalence of inflammatory bowel disease. The lower portion of the intestines can get inflamed. So Pam and Tony Guerriero decided to understand this. Let's tackle this too. And they found that people with Loeys-Dietz syndrome show very high levels of an antibody called IgE, something that associates with allergic conditions. They learned that there's very high numbers of these eosinophils, these cells that infiltrate tissues in the circulation. So we might have a marker that would allow us to identify which people with Loeys-Dietz syndrome are prone to allergy. They learned that the immune cells in the body are somehow, some way, producing molecules that are very pro-inflammatory, like interleukin-5, interleukin-13, interleukin-17. So it's telling us that there are chemical mediators of these inflammatory effects that might be able to be targeted. They found that people with Loeys-Dietz syndrome have very high levels of TGF-beta activity in the tissue where our immune cells mature, a tissue called the thymus. And they've also now learned that our Loeys-Dietz syndrome mice show all of these inflammatory states. Here I'm showing you the esophagus of a Loeys-Dietz mouse compared to a normal mouse. And if you do a stain to look for eosinophils, you see all those red cells infiltrating the tissue. So not only do we have new leads about what's causing allergy and what's causing gut inflammation, and what targets might be available to block this, but we have a mouse model that we can use to test all those. So that's a direction for the future. I want to end by acknowledging, the truly remarkable, energetic, brilliant young people that I have the privilege of working with every day, and also important funding sources, prominently including the Loeys-Dietz Syndrome Foundation. And I really thank you for your attention.